I think I'm recording. Yes, I'm recording.
Right. Oh, thanks, Ainsley. Right. So to start, thank you so much for being here in person and of course for online who are there. And on myself, I'm Dr. Supriya Subramani. I'm a lecturer at University of Sydney Health Ethics. And so to begin, as I acknowledge myself as a settler, a migrant scholar on the stolen land of the Gadigal people of the Eora Nation, I acknowledge that we are on the unceded sovereign land. Of course, as I talk about this, colonialism and imperialism are not just of history. They continue to exist and influence the present, and we all are witnessing this in different ways. And I stand in solidarity with all anti-colonial struggles. So in doing so, I also remind myself that unjust epistemic practices and genocides are two sides of the same settler colonial coin, and the way we need to acknowledge is something which I'm thinking myself very deeply these days. So today we have brilliant Dr. Suzy Killmister here, senior lecturer from Monash University with us. And this has been so exciting for me because it's a conversation series where we are emphasizing about the conversation. So Suzy here and Hojjat is the one who invited Suzy to talk about their ongoing conversations, which is happening at Journal of Medical Ethics. But we thought let's continue this discussion. That's what we are doing here. So I don't want to take much time. So we'll be talking about first, the format is Suzy will be talking for 20 minutes about on dignity and dementia care, are capabilities enough? That's the question which we are going to, Suzy would be touching on. And then Hoji would be responding or engaging or reflecting for 10 minutes, and then we'll open up the conversation. That's how it goes. Yeah, Suzy, please.
Right. Thank you. Yeah, thanks so much, Supriya, for organizing this event, and for Hoji for the original invitation, and for doing the work that this is basically a response to, which I'm really excited about that work. So really pleased that we can actually have this conversation in person. So this talk is kind of building on a response I wrote last year to a paper that Hoji published in the Journal of Medical Ethics, where he's taking Martha Nussbaum's capabilities approach and thinking about how it can be used as a basis for thinking about care for individuals with dementia, and dignified care for people with dementia. So I won't assume that people have read that exchange. So I'm going to give a kind of overview of that, but I also want to go beyond that rather than just kind of repeat what I've said here. So some of the background stuff will be covering that ground, and then towards the end, I want to kind of take my response, kind of push that response a little bit further, take it in a slightly different direction from what I did in the published piece. But I might just kind of start by flagging that, like, you know, when you're invited to respond to a published piece, you have to find things to criticize. That's kind of part of the name of the game. And you don't really, it's not really appropriate to kind of go on about how much you agree with and how wonderful you thought it was. But I'll take the opportunity now to say, I agree with almost everything, and I thought it was a wonderful paper, and I'm really excited about the project. But as you know, I'm a philosopher, so I will focus in on the stuff that I'm going to disagree with. But that shouldn't be read as a broader disagreement, because I think we're probably on the same page about this. So I mentioned that what Hoji is doing is taking Nussbaum's capability approach and then adapting it to think about dignified care for people with dementia. To make sense of that and to make sense of my response to that, we need to all have some basic idea about the capabilities approach. So apologies for people for whom this will be old hat, but I didn't want to assume that. So I'll just give a quick, very, very quick snapshot of what the capabilities approach is, and particularly the elements of it that are going to play a role in what's to come. So the capabilities approach, as developed by Martha Nussbaum, who's going to be our focus here, is an approach that she's been kind of developing and adapting for probably must be going on 30 years now. So it's gone through a few iterations. But at heart, at least in the more recent iterations, what she's construing it as is basically a theory of justice. So it's a theory of what the state owes us or owes citizens. We can think about it. She also has thought about it as a kind of theory of global justice as well. But effectively, it's about what we're owed in virtue, I guess, of our humanity. And for Nussbaum, what we're owed, how we ought to be treated, always comes back and makes a reference to what she calls capabilities. So for Nussbaum, capabilities are our freedom to do and be effectively the things that make us human. So what she's doing, or what she has done in this project, is try to work out what are the kind of core qualities or capacities that make us human? Or to put it a slightly different way, maybe more contentious way, what qualities or capacities, if they were lacking in an individual, we would say either that they weren't human at all, or at least that they weren't fully human. They weren't kind of living a fully human life. Her list, which I have shamelessly just kind of copy and pasted from Hojjat's paper, is on the top right of your handout. That's the kind of ones we'll be working with. But I'm going to introduce a little bit more terminology that is going to, again, prove a little bit important as we move on. So Nussbaum draws a distinction between what she calls basic capabilities. These are those kind of qualities or capacities that make us human. I'm going to use a toy example here, which is not one of her capabilities, but is easy to make sense of what's going on here. Let's think about something like playing the piano. Like, this is something that we might do as a human being. Okay, not what she thinks makes us human, but it'll work with me here. The basic capabilities for Nussbaum, if we're using Nussbaum's approach, would be our kind of a form of embodiment and a kind of cognitive sophistication that makes us the kind of creature that could play the piano. So on this account, an infant has the basic capability. No hope in hell they're actually going to play the piano, but they have the basic capability, right? They assuming, that they have, fingers or something that could be used instead of fingers, prosthesis, whatever it might be. They have the basic form of embodiment, and they are, if they were to develop, put in very scare quotes, normally they would have the kind of cognitive capacities to be able to play the piano. That's the basic kind of form. Then we might ask about, at some point in a later stage of the child's life, whether they have what she calls the internal capabilities. Here we're asking, in their kind of current state, are they able to play the piano? So we might ask, are their fingers kind of dexterous and strong enough? Have they developed the kind of cognitively and able to do it? Have they actually learned to play the piano? Are they, if the conditions were right, would they be able to play the piano? That's what we're thinking about, internal capabilities. And finally, we're asking about, or we might look at what she calls combined capabilities. And here what matters is A, that you have the internal capability, and B, that you're actually in a situation in which you're able to exercise it. So for our imagined person playing the piano, we'd ask, do they know how to play the piano? That's the internal bit. And do they have access to a piano? So it's all very well and good to be able to play, but if you never get access to a piano, for Nussbaum, it wouldn't count, as we wouldn't have secured your capability, right, for playing the piano. So what we want is to make sure that people can do the things that make us human if they want to. So we don't force them to play the piano, we enable them to. And then instead of playing the piano, we have the stuff on the list on the right. Those are what we're supposed to secure. So how this kind of the entryway for this to turn into I think a useful framework for thinking about care, and particularly care for people with dementia, is that for Nussbaum, we can use this basic idea as a way of thinking about human dignity. So for Nussbaum, what it is to have dignity is to be the kind of creature that has the basic capabilities. Unlike a lot of other kind of dignity-based approaches that get really speciesist at this point, so that humans have this special dignity and that's what makes us the only things that matter morally. For Nussbaum, each species has its own kind of list of capabilities, so it has its own kind of dignity. They're just different. We don't have to put them in hierarchy. So we have a kind of human dignity because we're the kind of creatures that have these capabilities. And then we can ask, right, have our capabilities been secured at least to some kind of threshold level? Are we able to develop these internal capabilities, and are we in a situation in which we can exercise them? If not, we can think of that as a violation of our dignity. So that's the basic approach. Like I said, as Nussbaum's been using is primarily a kind of theory of justice, thinking about what we're owed from the state or what we're owed global institutions. But it's really nicely, I think, adaptable to thinking about care, because all we need to do is think about what we're owed from institutions, right? So what we're owed from the institutions that provide care, or even potentially what we're owed interpersonally from people who we stand in caring relationships with. So to make that move, we just kind of straightforwardly say that we're owed the kind of care that secures our capabilities. That's what we'd be aiming at. Now, as Hojjat quite rightly points out, things aren't entirely that straightforward, at least when we're thinking about care for people with dementia. And the main problem with just taking a straightforward adaptation is that if dementia is advanced enough, it starts to look like individuals don't actually any longer have even the basic capabilities, right? And we can see that in particular if we look at the list here. We've got control over one's environment, which for Nussbaum means things like political self-determination, being able to vote, that kind of thing. Or we might think about practical reason, self-reflection, planning for futures, right? This is the kind of thing that once dementia is advanced to a certain point, we might say that we're no longer confronted with an individual for whom these things are possible. So how do we kind of think about care in that kind of situation? So Sufi's idea here, and I think it's a really excellent one, is there's a kind of a two-part process we go through to modify a capabilities approach in order to make it applicable in this context. So the first is to kind of take Nussbaum's list and adapt it, or he uses the term specify it, I might use the term maybe interpret it. We kind of get a little creative with how we think about the basic capabilities as Nussbaum kind of presents them. So we don't come up with a different list. You're not a different kind of creature because you have dementia. You're still human. We still think about what's good for you in terms of, you know, your ability to realize these kind of basic capacities. But we recognize that it might look a little bit different once you're kind of, you know, if your dementia's relatively advanced. So we kind of tweak our list a little bit. And we can see that list on the left-hand column of table 2 at the bottom of page 1 of that handout. That's the first step. But the other step we have to think about is that for Nussbaum, right, we really need to secure, you're kind of failing someone, you're violating their dignity if you're not both kind of ensuring that their internal capabilities are developed and making sure the external situation is such that they can exercise that capability. Nussbaum very much kind of, when she's thinking about it, she's thinking about like the development of those internal capabilities, so like providing children with a kind of environments in which they can, you know, develop their cognitive capacities, not kind of stunting particularly, say, women's development by depriving them of education or whatever the case may be. But when we're thinking about dementia, we're kind of thinking, I think, less about development and more about kind of degeneration, right? A kind of erosion of those capacities. So we need to distinguish between the kind of when our inability to exercise our capabilities is due to external circumstances, due to the circumstances we find ourselves in, due to the care that we're given, and when it's due to just the natural progression of the disease. Because it's not appropriate to think of it being a violation of your dignity if you can't achieve capability because, right, your capacities have eroded because of the progression of the disease. So we make those kind of tweaks. And then we end up with, I think, this quite rich account of what care needs to do and what care needs to look like. Right? So we recognize for every individual what it is that they're actually capable of doing in the right circumstances. And we try to provide them with the circumstances in which both their internal capabilities are secured to the extent that they can be, right? And we might be able to slow, say, the degeneration of some internal capabilities in the right kind of stimulating environment. Can't hold it completely, but we might slow it. So we'd have an obligation to do that. And we have an obligation to provide the kind of resources and environment in which, as far as possible, those capabilities can be exercised. I think that's great. And I think if that were taken as a model of the provision of care in care homes as we find them now, it would be a radical improvement. And we ought to do that. So this is not a kind of, in any way, a critique of saying, yeah, no, wrong path, let's start again. It's a way of saying, that goes an awful long way, but it doesn't go quite far enough. And it doesn't go quite far enough. I'm going to identify a little chink and then suggest that the chink is not merely a chink. It might be pointing to something a bit deeper, a bit more profound. And the chink is what I've circled on the table there with how Hojjat thinks about things like belittling remarks. So I'm going to expand on that and think about disrespect more broadly. So thinking about the full gamut from, you know, I know Supriya's doing some work on like micro inequalities, just minor little disrespects we might get in everyday interactions, ranging from that right up to what we might think of as like the kind of full-blown denigration that we see in like the Royal Commission report and things like that. So disrespect, broadly considered. On a capabilities approach, we say that disrespect is wrong insofar as it's wrong or when it's wrong because it damages or, inhibits somehow one of the internal capabilities. I think Hojjat is right that the relevant capability here is probably self-respect. That's how, by and large, we explain, the wrong of disrespect, how it affects us and our feelings about ourselves. The problem is, once we start thinking about people with quite advanced dementia, that connection between disrespectful treatment and the individual's attitude towards themselves can get broken. Because the individual might not interpret the action as disrespectful. They might not have a secure enough sense of self for that sense of self to be damaged by even attitudes that they do or behaviors that they do take to be disrespectful. So that causal relationship between the disrespectful treatment and the damage to the capability can be brought into question. But I think it's really important that we're still able to say that the disrespectful treatment across that full range from micro inequalities to full-blown denigration, that all of those should be considered dignity violations, and we have good reason not to try to prevent them in the context of healthcare. And what I think is going on here, the kind of diagnostic side of this, is to say that the capabilities approach is not the only kind of approach that does this, but it is one of the kinds of approaches that only attends to things that impact on an individual taken as a kind of, isolated being. So we look at them, we look at their inherent qualities or the developed capacities, whatever it is, but we look at something about them in isolation and we look at what's affected by that. Right? Utilitarianism would be another example of something that does this, obviously much worse. This is a much richer, better account, but it's still following the same pattern. And because of that, I think the capabilities approach isn't able to adequately address what we might think of as purely social harms. So what I have in mind here are ways in which we can be harmed, not just because our subjective experience has changed for the worse, but because our kind of social position has been changed, right? So we might be kind of put in an inferior position, a lesser position, a disempowered position. And I think that can be, we can think of that as a wrong, even if we're completely blissfully unaware of what's going on, even if it has no subjective impact on us. So that's the kind of diagnosis and an kind of indication of where I want to go with this. And so what I want to do in this final section of the talk is suggest a kind of, both a kind of pull back to kind of zoom out to think kind of more broadly about where the capabilities approach went wrong and how, or fell short, I should say, and how we might supplement it, what kind of approach would be needed to supplement it, and then kind of zoom back in for how we think about that in the context of dementia care. So I think if we're looking at something that might unite pretty much any theory of dignified treatment or dignified care, one thing I think we might find in common between them is the idea that dignified care is care that treats us as a person, or we might say as a human. I might be tempted to use that language, but whichever. And I think we can also kind of unpick that idea or just to draw a distinction within that idea of treating as a person between, on the one hand, the idea that I ought to be treated as someone who has a status of personhood, right? There's a kind of way in which you might treat me that responds to the kind of being that I am. And we might also care about whether we're treated as the particular individuals that we are, as this particular person. I think, look, I'm not a bioethicist, but insofar as I dip my toes in the bioethics water, I feel like there's a lot of consideration about the status side of the question, right? All the stuff about autonomy and informed consent, all of that, I think we can kind of put over there. That's, are we being treated as the kind of creatures, autonomous, rational creatures that we at least assume we are. But I think when we actually talk to people or listen to people and their experiences in the health system, they're just as often concerned about the personal thing, about whether or not someone's respecting them as the individual they are. So I want to keep that on the table too. So if we take those questions, like that raises the question then, if dignified care is care that treats us as a person, understood in both these ways, what is a person? So we need to know that before we can know how we can be treated as a person. And here I want to suggest that we can take kind of existing theories of personhood and divide them up very roughly into two broad camps. The camp on the left, I should stress, is way more populated than the camp on the right, but I'm interested in the right-hand camp for where I'm going. So the really common way to answer the question, what is a person, is to think about these internal qualities or capacities. Right. So any account that says that you have the status of personhood or humanity because you're rational, autonomous, list whatever ones you want, right? That's gonna fall that way. But I think we can also think about those kind of approaches in terms of the particularity question too, the individuality question. What makes me the particular individual I am? Well, it's my memories, or it's my values, or my beliefs, or whatever kind of cluster of those that we want to put. But we're always looking at what's happening inside the person. Those are on both the status and the individuality ones, that's where most of the action happens in philosophy. But there are accounts increasingly that look at what's happening on the right here, that understand personhood in terms not of, or at least not only in terms of what's happening inside us, but in terms of the relationships we stand in to others. So what it is to have the status of personhood on such account is to be embedded in certain kinds of networks of relationships, certain kinds of networks of institutions. I'm drawing here particularly on Maria Scheckman, who's quoted at the bottom there, and also Hilda Lindemann, if anyone's come across her, where the idea is that the Scheckman, she talks about it as occupying a position in person space. Are you embedded in the kind of institutions that we create around humans? Are you registers on births and deaths, going to schools? It's those kinds of things. Are you part of that? And then our particular selves, our particular individual personhood, we understand in terms of the relation, at least in partly in terms of the relationship we stand in. Right? I am who I am, the individual I am, because I'm so-and-so's daughter, I'm so-and-so's partner, I'm so-and-so's sister. That's the kind of idea. I want to suggest that we ought to supplement, not replace, but supplement the kind of like the internalist kind of view that the capabilities approach is, where we say dignified care is care that recognizes our status as autonomous, rational, whatever the case may be, and then we respond to the actual capability of the individual. And supplement that by saying that we ought to also, dignified care is care that treats us as a member of a particular of our community, where that means that we're treated in ways that are recognized as appropriate for humans, for persons, whatever the case may be. Right? So that's going to affect things like how we're clothed, fed, toileted in a caring situation, right? Irrespective of whether the person subjectively recognizes what's being done to them as disrespectful or whatever, there's ways that we kind of hold someone in their person, their humanity, by treating them as a human, as a person. And also as a particular individual they are in virtue of recognizing the relationships they stand in, helping to sustain those. Again, irrespective of the person's capacity to kind of continue to understand that they stand in those kind of relationships. So I recognize them at times, so I just want to wrap up then with this Scheckman quote at the end. She's not focused particularly on care, and she's not focused exclusively on dementia, but her idea is the kind of idea I want to point to of what dignified care looks like. She says it's possible to sing duets with grandfather who's suffering from severe dementia, even if he no longer has a capacity for moral agency or prudential planning. Carla can be brought out to picnic in the tree fort. Carla here is someone with a young person with a very severe cognitive impairment. Children who are too young to count as Lockean persons can be brought to sporting events. This is the kind of idea we incorporate people into these practices as a way of treating them as a human being, treating them as a person, and that's a way of treating with dignity. I'll wrap up there and happy to answer questions about what that might look like and why I put elections on the list in Q&A.
Is that okay?
No, yeah,
yeah.
very quickly before we keep going, I just had a query from someone online about the handout.
Oh.
Are you comfortable with me?
Oh, absolutely.
taking
Yeah.
that photo?
Yeah.
And I'll send it to Belle, who might be able to put it in the
Sure,
chat for
thanks.
all the online folks. Let me send the PDF. I have one. Yeah. Oh, you have a PDF. Oh, cool. If you just email that to Belle, she's giving us a thumbs up. Perfect. And then she can pop it in the chat, or you could even put it in the chat, whatever's easier. Thank you. Hojjat.
All right. Yeah.
Technical solution.
Thanks, Suzy. It was a very generous, clear, and articulate engagement with my work. I'm really grateful for the critical feedback as well. So I tried to be as concise as possible. and I try to focus on a couple of items or points that I am also thinking at the moment, and I want to draw on them in further discussions and conversations with you and people who are here. So one of them is about the idea that we can supplement the Nussbaumian approach to dignity with your approach to dignity. And by the way, I have to flag here, Suzy was humble enough not to mention this, but Suzy has written on dignity extensively, and Suzy has a fantastic book called Contours of Dignity. I recommend to everyone who wants to learn more about Suzy's perspective. And I specifically draw on that account of dignity. So I'm not so sure that, and you actually flagged that in your response to my paper, that the supplementing Nussbaumian approach with your conferralist, that's how I characterize your social conferralist account of dignity, could be, I think you flag whether or not that's possible or that's desirable, and I'm also not sure about that. And I just want to kind of flag that now, and I want to kind of explore that more. So I wouldn't be able to go in detail. And one reason that I think that I'm not so sure about the possibility or the desirability of supplementing is that there is something in the Nussbaumian approach that is not in the socially constituted account of dignity as you characterize. And that's the focus on something about the person. So what I take your account of dignity is that it's not primarily, at least, something about the persons that grounds attribution or attribution of dignity. It's something about the social norms or something about the social regulation of norms. And that's my kind of first pass explanation of why I'm a bit unsure about the possibility of supplementing. Another point that I want to flag is that so you mentioned the concept of disrespect and then personhood, and I thought that we can have an account of dignity that has its own limitations in the context of dementia care. And that account of dignity can help us make sense of certain wrongdoing and certain ways of acting on our moral obligations. But that's not the only concept, presumably, that we can have in our moral vocabulary or lexicon. We can have a concept such as personhood. And I don't think tying the concept of personhood fully to the concept of dignity is our best shot. So simply put, I might grant that the Nussbaumian approach to dignity, as I characterize it, has some limitations. But fortunately, we are in a position to to explain or to give an account of why certain attitudes, certain acts, or certain omissions that you track are dignity promoting or dignity, are wrong or right, while appealing to other concepts. So that's the kind of the second point that I try to make, and maybe we have space for another. Okay, so a third point, and this is more about the conferralist account of dignity. It's more about the concept of social norms that you appeal to. I think that there's some form of social contingency in that way of theorizing dignity and that way of theorizing social norms. So to some extent, it's the kind of norms that you are referring to are locally determined or locally established or maintained. But there's nothing. But there's nothing substantive significantly about those local norms, and by that I mean we might think that in certain contexts or in certain settings we might have certain social norms or certain social expectations, But on your account, there's no guarantee that we can extend or they are extendable to other contexts or other settings. I grant that there might be a bit of misreading of your book, so hopefully you can challenge me and correct me on that. But I thought that that level of social contingency is a high cost to pay for making our account of dignity as inclusive as possible, or in your account, perhaps fully inclusive, because that then can be inclusive of every person as long as the social norms endorse that extension, or the social norms endorse that human has certain entitlements, which I think you presume is there. Okay. I hope that this was clear. This was just a first pass response to Suzy's rich account and talk. So I stopped it.
I think, I mean, I really want to see going back and forth. I'm so tempted, but before I ask so many questions, or even like we are here, I want Suzy to you want to respond or reflect? Oh, yeah, perfect.
I think that's why I can wave at people. Yeah, thanks, Hojjat. Thanks so much. And apologies, I didn't send you a written version of this talk, so you weren't relying on all the stuff that I'm not organized enough for that. I'll respond to, I think, the second 2 points that you made, because they're fresher in my memory, and I'll do them in reverse order. So in terms of you took quite right that on my account, both in the book and in what I'm talking about here, when I say that we need to treat people in accordance with norms, local norms, in order to uphold their dignity, it is contingent and it's subjective and it's contextual. Why I think that's important, and thinking about it particularly in the context of, say, elder care, if we think about something like how someone is fed in a care home, I think what matters on my account is what are the local norms, because that's a way of kind of showing respect or ensuring they're kind of included in the community. So if we think about something like whether or not you eat with your hands or whether or not you eat with utensils, and where this might be a part but imagine someone who's kind of fight far advanced in dementia but can still kind of manipulate utensils if they're given them. To not give someone, say in an Australian context, not give someone, for whom there are other extenuating circumstances, just to not give someone utensils to eat and so forcing them to eat with their hands, on my account would count as a kind of dignity violation, because that's how we do things here. We don't need to it doesn't matter whether there's some underlying moral reason. I don't think there is. And in a different social context, it'd be perfectly appropriate for someone in an aged care home to eat with their hands, because that's how everybody does it. So I want that level of how do we do things here? It needs to it needs to be that subjective in order to do what I want it to do. It carries risks. I'm going to knock those off for lunch because we'll talk about them later because they're too hard. The other point was around whether dignity needs to do all the work. And look, I am in full agreement that dignity shouldn't have to do all the work. And last thing I want is to get into a terminological dispute about dignity versus other things. But I would say, nonetheless, let me do that anyway. I would say that at least there's certain kinds of things that strike me as paradigmatically in the dignity camp rather than something else. And I think things like leaving an elderly person in soiled bedclothes, I mean, it's not an autonomy, sure, but we're stretching. There's other things we can say, but to me, it's well, dignity is where that goes. And then how do we have to think about dignity to get it there? I think we need to have something more than the individual themselves. That's kind of where I'm going with this. I think the reason why both the norms get in and that I want to put this in the dignity camp has to do with if we start from what I take to be pretty paradigmatic example of dignity violations, particularly in, say, aged care situations, they look like it's dignity that's going on, and often the only way we can explain that is by kind of pulling out and maybe abstracting away from the particular capacities of that individual. So that's how.
Right. Oh, thank you so much. I mean, it's talking about disrespect and talking about the dignity questions. It's so central to the way I think about humiliation and shame and what it plays a role in those relationships. And I completely resonate with the way you talk about the social positioning. But then the other question, which I was thinking with the dementia care, is basically, I think, which we had a brief discussion about self-awareness. So if most of the, especially in the, the end of the spectrum of people who do not recognize themselves in a way which they want to. So how would you think about making sure that a relationship, if you emphasize the role of, let's say, mother or father who's playing that intersubjective relationship playing out? So what kind of respect or dignity you think would capture best without capabilities?
Yeah, I haven't thought enough about the particular interpersonal relationships for this. So I don't, the short answer is I don't know, but I maybe feel more comfortable kind of tweaking that, thinking about, say, like someone like a nurse or someone with a kind of authority position. And I think I think the aim should be treating as an equal. But we might want to have different thresholds between like what's the ideal we're aiming for and what is the kind of behavior that we might think is like, it'll get you fired, right? Like, and there's going to be a gap between those. So I think it's just going to be a threshold, right? We can kind of make a strong or weak demands on people for how they think, the way in which they interact with people. But I think and just thinking about these interpersonal relationships and their effects, having the kind of parallel approach where it's like, what's the subjective effect on the person and what is it actually doing in the social positioning? Part of that's important, I think, in these contexts, because when someone has dementia, not only do they fail to see the disrespectful treatment is disrespectful, sometimes they kind of misconstrue, actually quite often misconstrue. And I think if we're only focusing on what's the effect of what you're doing on on the person's self-respect, that's going to make the lives of those who are doing the caring impossible, right? So there has to be some way they're kind of getting it right that is independent on the subjective effects, which isn't to say that the subjective effects don't matter. You minimize the stress, you do what you can. But I think we also, if treating as an equal isn't recognized as such, it's still good. And now we might have to do a trade-off. If it makes you feel distressed, then maybe we find some other way of treating you. But we recognize it as a trade-off rather than as the only thing that matters is like, how are you interpreting what's going on, where that can get very distorted.
Oh, thanks. Sorry, I just started off with my privilege of asking you questions. Please raise your hands who are online just to make sure that, okay, yes, there you go.
Do these microphones?
It works, yes.
No.
Yeah, I think it did work.
Yeah. Look, thanks so much to the both of you. I think the answer would be in your book. So I think the answer is I need to read your book. But given that I have. So with regards to what is a person, and you have kind of the more dignity thing on the relational side of things, right? And you mentioned like as a member of the community. I'm wondering, I guess, what's the role of the plus sign in your diagram?
Yes.
Sorry, and I don't mean pedantically, but like, is the idea that a person like can you have completely like shut off the internal part of what's in the head and still have a person? What's the relationship between these two things? And again, I assume
the answer's not in the book. It's actually what that last little bit is what's going to go in the next book. So I'm transitioning from like the dignity book's about dignity. The new book's about humanity. So I'm kind of broadening out a little bit. So some of this is quite new. But in terms of, the answer to your question, which you won't find in the book, is that the plus is about how I'm using that in terms of how we treat people as a kind of default, right? So in order to respect you as a person, it's not enough just to focus on the relational stuff. It's not a replacement here. Like I can't just say, well, I'm including you in all the parties or whatever, but like your actual individual capacities, whatever, doesn't matter. Like I think it's a requirement to do both. But it's also a kind of, insofar as someone might not manifest one side of that equation, then all that would be left with the other. And that would be enough for them to be a person on my account. Now, you have to get a bit kind of weirdly sci-fi to kind of think of someone with the internal capacities without any social relationships. But imagine, if there were such a creature, there'd still be a person and we'd still owe them something like the capabilities approach way of thinking about, helping them develop and realize what they can do. But I think more commonly with the kind of situations we encounter are people for whom those basic capacities are very, possibly non-existent. And I want to say we have a choice to make about whether or not we kind of continue their humanity. We can do it. We can make them continue to be human by continuing to incorporate them. And there's very difficult questions then about when is the time to let go. But they're not solved by, that question's influenced but not determined by what's happening on the left-hand side of that diagram. That's the way I have it.
So just further clarification. So essentially, if somebody's dead,
Yeah.
right, which is obviously the
Limitation. Yes.
right?
Yeah.
So is it a matter of like we just have duties to the dead, as it were, in terms of like community norms, or is it rather that is that person still part of humanity, still a person in some capacity? I'm wondering what your.
Yeah, I think for me it's going to be very culturally specified.
Gotcha.
So I think it's theoretically possible to continue to have the dead to be part of humanity.
Right.
And there might be reasons to do that, reasons not to do that. I don't think Western liberal society typically does that, but I do think that we do have practices, if we actually look at them, that it's not immediate.
Sure.
When someone dies, and I think those practices that we have around funerals and things like that are a way of kind of keeping someone in the community just for that little bit longer. So yeah, it's up to, basically it's up to us how we do it.
Yeah, these questions are so much. I wish another 2 hours of this conversation. Laura, I'll just take this online question and then I'll come to Inslee. Please, Laura.
Hi, can you hear me okay?
Yeah.
Suzy, I'm so disappointed I can't be there and see you in person.
That's okay. I appreciate you keeping your germs away from me. So thank you.
I know exactly. So I'm totally on board with the project. I think you're right that you need to supplement the capabilities approach to make sense of, dementia in aged care settings. I'm quite on board, but I was wondering if it's right to say if there's still a problem there that needs to be addressed. And in response to one of the questions, you said that, it's important that when you have dementia, that you still treat it the same way as everyone else. So if we all use cutlery, then, the thing to do is to make sure that someone with dementia is also getting the cutlery. So equal treatment is a way of respecting their dignity. But it seems to me that sometimes when there is a kind of extreme form of vulnerability, equal treatment just won't be enough. So what I'm thinking is that in aged care settings, say for-profit aged care settings, it seems like people with dementia are particularly vulnerable because they can't advocate for themselves, right? The motives, they're particularly vulnerable for having their kind of core interest disregarded, partly because they can't advocate for themselves. And then the motives on the part of the workers seem, if everyone working there is kind of just the culture is one around profit, and you're all just trying to get the work done very quickly, etc. It seems like it's problematic in a way that's not problematic for other clients or residents who don't have dementia, can speak for themselves and can advocate for themselves. I don't know if I'm making myself very clear, but basically there's a vulnerability that comes with having dementia that makes it the case that settings have to be even more attentive to the core interests of the person with dementia because they can't advocate for themselves, such that equal treatment is just not enough.
Totally. Actually, thank you. That gives me a chance to clarify the bit that I rushed really really egregiously at the end there, which is what I mean by this kind of having the treating the same as everyone else in the sense of the norms of applying. So what I have in mind here isn't identical treatment, because that would be really really problematic. I mean, not just in horrible for-profit care homes, in any care home, right? Even the best care home, like the idea that you would give someone dementia a steak knife is probably not a great idea, right? It's not going to work very well. So really what I'm trying to get at is the idea of someone to whom those social norms apply, which isn't to say that the right thing to do in the circumstance is to kind of force them to try to themselves uphold the norms. It's to recognize that when they can't, we do what we can to kind of, I guess, grapple with the difficulty of the norms not being able to be upheld. So I think of this particularly in something like toileting as the right kind of example here. So, you know, it's certainly in my culture, you go to the toilet alone, right? That's how we do things. And sometimes, you know, not just for aged care, but in any kind of real vulnerability situation, someone who's physically incapacitated might not be able to do that. And then we think about, like, okay, given that we're in a society where the norms of privacy are that you toilet on your own and you can't, how do we grapple with that? And I think it's about that very interpersonal relationship in that moment of that recognition that what we're doing here isn't able to uphold those norms, and we treat you in such a way that that's kind of acknowledged and respected. How you make whether or not you make eye contact, what the kind of conversation you have while you're toileting, not treating it as like, well, for someone like you, it doesn't matter. I mean, that's what I'm really getting at. That's where I think we start to slip in treating someone with dignity. It's like, oh, for someone like you don't even notice, right, that I'm here, or like, you don't seem to be embarrassed. So we'll just kind of, you know, I'll just treat you completely differently than I would treat someone, you know, who maybe broke a leg and needed help. So it's that recognition of the norm applying and then navigating what that means in a particular situation, given the kind of physical and cognitive limitations someone might have. So it's often going to, in the kind of for-profit situation you're talking about, I think that's going to involve, incredibly close attention to people's individual needs, people being able to advocate for them, all those kind of things. But even in the best case scenarios, I think it's going to mean really kind of close attention to what the person can and can't do, and kind of helping them navigate those situations where they're not capable on their own of upholding those norms. Thanks.
Hi, Suzy. I'm Ainsley. I'm an academic at Sydney Health Ethics, a colleague of Hojjat's. Thanks so much to both of you. It was really fascinating. This is not really much anymore a topic I delve into very much. And so my question, I hope, A, makes sense, and B, isn't ridiculous. So it's motivated by, I work on, you know, super practical questions. I really like my kind of way of kind of trying to sell myself as an academic when I'm asking for grants is to say I do, you know, practical problems. I solve real world issues. So I'm coming at it from that way. And so what I'm thinking about is there's going to be a time. Actually, I'll just say one more other thing too. I really like how you're encapsulating personhood, because I think your account is going to be able to deal with a lot of the critiques of personhood theory. And, you know, I've written a book chapter on this, albeit a really long time ago, and it seemed slightly intractable at that time because of the kind of inherent subjectivity and the existing in the head of the person type limitations, which you outlined really clearly. So from a practical perspective, a person receives a dementia diagnosis, or they have an onset of symptoms to a point where it becomes clear that they can no longer hold capabilities in the way that perhaps Nussbaum intended. And what I'm interested in with the account that you're proposing as a way of sort of, I guess, as an alternative to extending capability or trying to sort of use it in some way, is we'll have a very practical point at time in which we sort of have to switch accounts, and just, you know, I guess how that might happen and whether you've thought about that. And then the other thing is, you know, are there other ways that we can rescue capability here? I don't know. And this is the worry that this is a ridiculous suggestion, but are there ways that we can sort of adapt capability theory so that it doesn't necessarily have to rest in the current ability to hold a capability, but more perhaps we're respecting a capability once held, or where it's kind of almost capability meets substituted judgment, which I know is its own, you know, big bucket of problems, or other, you know, ways of trying to make the best decisions we can for people who can no longer do that themselves. I think also, you know, I've done a tiny bit of work in the past on like Ulysses contracts and things like that. And you often have this case of someone who has dementia and the way they feel and think about themselves just is a complete transformation of who they were before they became demented. And so I worry that that might also go against even my idea of thinking about it. But just to summarize, sorry, a bit meandering, I guess my motivation for my question is, if we want to still try and use capability theory for other points in our lives, we're going to have this kind of practical barrier at which we have to kind of switch over to thinking about it differently. And that might be easy or it might be hard. And in order to maybe avoid that or do it alongside, are there different ways that we can rescue capability theory? That's where I'm coming from. Thank you.
Great. So thank you. No, that's really helpful. And I need longer to think about all of it. But in terms of the switching, so I guess how I'm thinking about it is actually both the kind of inherent bits and the relational bits. For most of us operate alongside the whole time. So for a lot of the ways that we ought to treat people, I think that there's going to be a really close overlap in we can justify it either through, that's a respect for you in terms of your inherent capabilities or your particular personal qualities or whatever the case may be, and it's a respect for you as a person in the relational sense too. Those will often cohere. And I think that will continue to be so for quite a long time. There'll be a kind of maybe a fade out rather than a fade out of one rather than a switch. So if we think about something like, one of my examples of how we like hold someone in personhood on the relational side of you invite them to birthday parties, right? Well, like that's not a change, right? There's a change in a justification for why we're doing it. And there's never going to be a clear-cut moment. And, and often there'll be a drifting in and out with someone in dementia. Like sometimes they know that they're there because they're someone's grandma. Sometimes they don't. And so if we've got the two reasons and they coalesce, and it's fine. We just still keep doing the thing we're doing. That our reason for doing it slowly kind of, it used to have a double justification and one of them kind of fades out. They will clash sometimes. And I think the way that kind of thing where someone's kind of like they lose their original sense of self, from the internal kind of point of view, and now they have different kind of values and beliefs and so on. That gets tricky, right? Because on the relational view, those long-standing relationships kind of are part of what make you who you are. And, for a long time, those will have developed in tandem with your beliefs and values and so on. And then when those switch, now we might get attention, right? Respecting you as someone's loving sister, say, might be in tension with, yeah, but now you hate that guy that you don't know is your brother, right? And so how do you, I just don't think what I think my account gets right is that there is no clean solution to that. We're in fact just in a situation of having been pulled in different directions, and we oughtn't just gloss over that. So part of what I like about my way of thinking about it is it doesn't simplify problems that are not themselves simple. In terms of rescuing the capabilities approach, I might hand that to Hojjat because I don't know. At some point it might stop being a capabilities approach, or Nussbaum might not think it's her capability. I don't know. I'd be curious to know how much we can tweak.
Yeah, so I think one thing to be clear is what we want to rescue from the capabilities approach. So is the objection is that it cannot account for the kind of presumed dignity violations that Suzy tracks. So I'm not sure actually they are dignity violations. So I think they are wrong. We have good reasons to think that they are wrong actions, but I don't think they are. So I don't think the wrong-making feature of actions is violation of dignity. Maybe it's other consideration, but okay, for the sake of argument, let's say that that's the wrong-making feature of the actions. Then I think, yeah, we can also perhaps talk about modal capabilities, like capabilities that people never have had, never will have, but because of their membership in certain social groups, we can imagine that they might have had that capability or capacity. And this applies to people who very disabled, or children who have significant disabilities and would never get to the kind of cognitive functioning that other children get. And in those cases, so I'm broadening our focus now from dementia to other domains, because I know that that's also one focus of Suzy's work. And in those cases, then we can talk about modal capacities and capabilities, or in the context of dementia, we can talk about capabilities that people have had at some point, and then we have to treat them in certain ways that respects their previous dignity. I'm more positive about the modal sense of capabilities, than respecting people in ways that treats their previous capabilities. Because I think to some extent, the notion of capabilities has some contemporaneous underpinnings, and it's very hard to do that in the way that you suggested. Modal capabilities or capacities, maybe yes. So that's my first again answer.
All right, there is the next session. So we're gonna rush off. Thank you so much for being here. Thank you so much. This has been so great. Yeah. Thank you for all who joined online. See you all for the next conversation.
Thank you.
Thank you, Suzy.
Yeah.